Good evening. Welcome to POOIA, Professional Organization of Iranian Americans. One of the missions of POOIA is to honor, pay tribute, as well as to learn from our Iranian American scholars, scientists, and dignitaries who have made a difference in the world. Tonight, we are privileged to have a young professor and an eminent psychologist as our guest speaker, namely Dr. Neda Moinolmolki, for which I am truly indebted to our dear friends, Ms. Behnaz Rohani and Mr. Shahzad Bagheri, for having introduced her to us. POOIA is an affiliate of Kanun or Persian Cultural Center and is a non-religious, non-political, and purely an independent organization. I have the honor of being the president of POOIA, which has a board of directors different from that of Kanun. The lectures are all in English so that our Iranian American generations 1.5 and 2, who unfortunately do not know Farsi, can benefit from them. POOIA works tirelessly to uphold the three pillars of its mission. Number one, to provide an opportunity for Iranian American professionals to network and support each other. Number two, to help the next generation of Iranian American professionals to succeed and prosper. Number three, to promote a positive image and counter the negative media depiction of Iran and Iranian professionals. Please support POOIA by donating via POOIA.net, POOIA, POOIA.net. Now I will briefly introduce Dr. Neda Moinolmolki. Dr. Neda Moinolmolki has a BA in psychology from Stony Brook University in New York, a master's degree in general psychology, and a PhD in psychology from Queens College. She is an assistant professor of psychology at Albertus Magnus College and is passionate about the application of psychological science in fostering a more equitable and inclusive world. She has notably received the Distinguished Contribution to the Science of Psychology Award from the Connecticut Psychological Association. She is actively involved in several social justice research initiatives, both locally and nationwide. She is the author and co-author of 12 or more articles published in highly reputable psychological journals. And remember, she's very young, Tonight, she is going to talk about the intersectional inequities in the face of COVID-19. Neda Jun, on behalf of POOIA and Kanun, I actually thank you so much, for accepting our invitation, and we are all ears. Thank you so much. Would you please start?
So I will be getting started, and please, if I'm speaking too fast or if there are any things that you don't fully understand, don't hesitate to kind of interrupt me. One thing I want to quickly highlight before I even get into my lecture is to kind of emphasize the fact that I have more of a developmental psychology background, not a clinical background. And I think that's a really important thing to decipher. My training centers more on holistic, systemic models of well-being rather than looking at clinical-based issues within the field of psychology. And so this presentation, what I'm going to be doing is talking a little bit about the structural, intersectional inequities that we have seen in the face of COVID and also beyond. And I've centered it a little bit more towards the field of medicine, just because I feel as though it's something that anyone can really relate to, regardless of whether you work in the field or whether you're just a regular person that is dealing with the health issues and the consequences of COVID-19. I always start any lecture or presentation that I have kind of just acknowledging the fact that, we live in a country where there has been genocide and enslavement, and, coming to terms with the fact that we have to recognize that and make sure that we're kind of advocating and helping to stand with many of the enslaved individuals who helped shape our country today. And I think that this presentation is going to really highlight the value of that. So the first thing I want to just quickly talk a little bit about, and I use a lot of tables just because I know that it's more user-friendly for people to be able to digest, is that, when we look at COVID-19, especially between the time in which it was prevalent within our society, there were definitely, race-related disparities that we saw in terms of not only infection rate, but also death rates. And this is actually a table that comes from the Census Bureau as well as the CDC that just was looking from 2020 to 2022, how many people out of 100,000 were being infected with COVID-19. And right from here, you can kind of tell that there are definitely disparities. And so the first category, the one that says NHOPI, is Native Hawaiian or Pacific Islanders. And they had the highest, rate per 100,000, and that was followed by Hispanics, and then followed by American Indian or Alaskan Native. And so you can see that there were definitely disparities, and, clearly Asians seemed to be more protected compared to the other races. When it comes to mortality rates, it seems pretty similar, but there were some little shifts here and there. And this is mortality rates out of 100,000. And so what you see is the American Indian or Alaskan Natives had the highest rate of mortality. And that was followed by Hispanics, and then followed by Native Hawaiian or Pacific Islanders, right? And so clearly we were seeing stark disparities when it came to mortality rates. And so this is kind of that upper level, right? And we're going to dive in more as we move further. It gets a little bit more challenging when we actually look at race and social class. And one of the things that we typically just think about is we think about all these things kind of in different categories, but there are a lot of intersectionalities. And if you just look at gender or you just look at race, you're missing out on a lot of really interesting and important components. And so with this table, I know there's a lot going on. I'm going to kind of summarize and then go to the next slide that's going to help to condense it. But the lighter colors mean higher levels of education. The darker colors mean lower levels of education. And the blue is for men. The orange is for women. And so you can right off the bat see that, clearly white women are doing a lot better when it comes to mortality rates compared to all the other kind of intersectional categories here. And one thing that also is really interesting is that when I was looking at this table, just the fact that a white working class woman with no college degree at all or hasn't even taken any courses has higher odds of surviving COVID than a Black man or Hispanic man who is a college graduate, right? So to me, that was really startling to kind of think about and look at. And the things that kind of stood out in terms of the intersectionality between these two is when we look at the highest rates of mortality, the three major groups were working class Hispanic men, working class Black men, and working class Black women. And one thing that we know is that women generally tend to live longer and tend to be healthier. And so the fact that Black women were in that category is saying a lot. And then on the other side of the spectrum, the lowest level of mortality were college graduate white women, college graduate white men, and then white women with some college degree. So no other racial group came up in here besides white Caucasians. And then, as I had kind of mentioned earlier, the thing that really, stood out to me was the fact that, working class white women had lower age-adjusted mortality rates than Black and Hispanic men of all educational backgrounds. And we do know that education plays a role in, health, but yet it seems as though your race also plays a role within the country that we live in today. Some other things I wanted to kind of highlight, and I may have to move some of you all so you can see the bottom here. What this table is kind of showing you is at the bottom, it's the percentage of time that people were not able to work remotely. And so anyone at that lower end had the flexibility to work remotely. People who were at the higher end of this table, towards a 90% or 100%, meant that they had to work. They couldn't work remotely. They were basically forced to be outside during COVID. And the bubbles are actually represent different social class and gender categories. And the dark blue is working class, light blue is some college, and yellow is college graduates. And so clearly what we're seeing here is that people who had college degrees were less likely to kind of be on probably the front line and less likely to die of COVID. But of course, there are multiple factors in this, right? So it depends on what type of job you're doing. If you do have a higher levels of education, even if you are in the front line, you're more likely to take more precautions or have the expenses or the opportunities to be able to take those precautions. And so I thought this was just really interesting imagery to kind of look at, socioeconomic status and education and how that impacts people's privilege to be able to work fully remotely. Some other things that I think are important thinking about kind of a little bit towards the post-COVID era is about medications, right? And the medications that we know are effective to help people who may be immunocompromised. And what we do see in terms of trends is that there are disparities between individuals who have access or get treated with these medications and the individuals who don't. And so white individuals were more likely to get treated with these medications compared to many other demographics, including even Asians, right? And so there's disparities when it comes to either access or to the ability of their connections to be able to get them the medications that we do need. And this is something that is worrisome, especially for backgrounds where they may not necessarily, where they are vulnerable and they have health issues, but may not be able to get the access that they need. And this definitely has an interacting relationship with those mortality rates. Other things that seem a little bit far-fetched from health, but they really do interact, is thinking about the implications of the pandemic on food insecurity within the US. And we don't like to really think about this, and it's hard for many people in the US to kind of accept this because we live in a culture where there's, this fear of obesity and this idea that that most people are having way too much access, when in fact, we do have people in our country that are struggling. And so as of today, 1 in 5 communities, people that live in them, can't get access to necessities such as food. And this definitely has gone up since the pandemic. And I believe some of that is related to the fact that schools did shut down, and many children that were low income oftentimes were getting free meals in schools and in preschools who were then home and could not, especially if they lived in regions where their parents may not have a car and they may not be able to go to a supermarket to get the resources they need, or even go to any type of food clinic to get the foods they need, right? Churches that would donate food. Some other things that I think are important to kind of highlight and look at is that, thinking about some of our more vulnerable populations and food insecurity. And so when we look at the percentage of children in the US who are food insecure, that's about 8.8%, which is a significant percentage. And I definitely can say that in my experience working in college settings, post-COVID was the first time where students would disclose that they were struggling with getting access to food. And we have a mobile food pantry that comes once a month that parks on campus in the parking lot. And each month we have at least 40 students who line up. And for me to think that these are students that are struggling that much, that they feel that they're so desperate to even be online on campus where people are walking by to get the food, is really kind of showing how many people are susceptible to this. Also, we can't ignore older individuals in the US. And so about 8.1% of older individuals in the US are also food insecure. There are also disparities within food insecurity when it comes to looking at older individuals. And so, and the duration of COVID. And what's really fascinating is that the only group where we saw a decline in food insecurity was actually whites. Every other, sub racial group, we saw increases in. So we saw stark increases in Black populations, smaller increases in Hispanic, and we also did see a little bit of an increase in Asian populations. So we're seeing that there are these disparities within individuals who are food insecure above the age of 50. One thing I want to kind of talk about is, yes, we know that, but like, why is this important, right? And this is something that makes sense to us, of course, when we think about children. They're developing, there are nutrients they need, there are risk factors that, are there if they're not receiving, or they're not getting access to high quality foods. And so what the research shows is that food insecure children are at least 1.4 times more likely to be diagnosed with chronic health issues like asthma. And we believe this has a lot to do with their immune system. So if they're not necessarily getting food very often, their body is going to be automatically more stressed, right? And that can lead to the exacerbation of inflammation, as well as if they are food insecure, they're probably living in regions where there may be a lot more pollution, or there may be toxins within the buildings that they live in that could be leading to this. And I do see a hand, so please feel free if you want to ask a question.
Thank you so much. Afterwards, after you're finished, we
okay.
start the questions.
Some other things that are also important to think about is that, yes, we know this does lead to increased risks for poor health, as well as a lot of different types of deficiencies that are really challenging for many medical doctors to deal with, because they know that once these children go back into their everyday life, they're probably not going to be getting the access that they need in the long term. It also, in the long haul, leads to other mental health factors such as depression, anxiety, and attention deficit disorder. And a lot of this stems from that trauma of just never knowing where that last meal may be, right? We don't think about it so much as trauma, but for a young child, it could be very, very stressful when they're not always getting access to the foods they need. And oftentimes, as these individuals get older, they may develop even issues with food because of the fact that their bodies have been kind of hungry for so long and whatnot. When it comes to older individuals, What we do also know is that research has found that individuals who are older and food insecure tend to age faster. There's something related to that, as well as when we look at their levels, amounts of like physical limitations in their daily living activities, they tend to exhibit higher levels of that. And this can have like compounding implications on their physical health, because they're more prone to falling or getting into accidents because of the fact they're not able to do things as well as they could if they had the proper nutrition. Some other things that I also think is kind of important for us to look at, and I know that many of you do live in the state of Georgia, and there are some excellent resources out there that kind of look at many of the intersections of sociospatial and economic segregation and the implications that has on COVID-19 transmission and mortality. There was one study conducted in the state of Georgia, which was published this year, that had found that when they looked at the socioeconomic disparity factors, counties with the largest income disparities had about 1.57 times the cases of COVID-19 and about 1.7 times mortality rate compared to the most privileged counties, right? So, these counties with those, with those income disparities, people on all levels of those income disparities are suffering in those regions. And then when we look at also, racialized economic segregation, what research had found was that people living in more economically and racially segregated regions within the state of Georgia were about 1.8 times more likely to be hospitalized due to COVID. So we are seeing, and it's hard to say what's causing what, right? These are kind of like, research is more correlational in nature, right? But clearly there are these trends that are kind of showing us where you live may have an implication or impact on some of these factors. One other thing that I wanted to talk a little bit about before I get into the next study is something known as social vulnerability factors. And we're going to talk about social determinants of health, which some of you may be familiar with, some of you may not be familiar with. The CDC actually has a social vulnerability index where they collect data and develop kind of maps that calculate this index. And what this index kind of looks at are the various factors that relate to people's long-term health, right? And they measure these things in different communities to kind of get a sense of what are the risk factors for people living within those communities. And this particular index looks at 4 different components. And so, of course, socioeconomic status, we all know that education plays a huge role, your income plays a huge role. Whether you have health insurance, we all know a lot of that plays a huge role with health. There's also household characteristics, right? So what type of household do you live in? Is it intergenerational? Is it not? Do you have an individual with a disability or not? Is it a single parent household? Or, is it a household that does have individuals who have, English language issues, right? We have a lot of immigrants and refugees that come into the US that may not know how to access information because nothing is really translated on websites. And then, of course, as I kind of highlighted earlier, there are definitely race and ethnic minority status components to play a role. And then lastly, there is kind of components of communities related to housing type and transportation. So the quality of individuals' access to quality housing, as well as the communities that they live in. Do they live in areas that are more rural compared to urban? Do they have more access to public transportation? Do they live in areas where there there are quote unquote food deserts where they may not have access to supermarkets that are out there, right? And looking at overcrowding, which is a huge factor, especially with COVID-19. And so generally, when this particular factor is used, they have this range of 0 to 1. So if your county scores close to 1, it has the highest level of social vulnerability. If it scores closer to 0, it has the lowest level. And in the study that I'm going to kind of talk about now, this is often kind of divided into quartiles. So that, first quartile, second, third, and fourth, and higher quartile means that there's higher vulnerability. And what we do see in this particular kind of table, and let me, move you all over again. I always forget about this. What you're seeing here is a table that's kind of showing you the social vulnerability index and kind of what that looks like within the US. And there was a cross-sectional study that was conducted that was looking at the relationship between the social vulnerability index and mortality rates after the onset of COVID-19. And what they had found is that US counties in the most socially vulnerable quartile, so that highest level, had significantly higher increases in mortality rates of all causes during COVID-19 compared to counties in the least socially vulnerable quartile. And so what's important here is not just mortality from COVID-19, but also mortality of all causes, which I think is really important for us to highlight. And within this table that was taken from the CDC, you can kind of see that the areas that are lighter are the areas where we have lower social vulnerability, and the areas that are hot, darker, we have higher. And so you can kind of see there's almost like that north and south divide. And there are certain sub-regions where, people are kind of in that higher area. We can't talk about, mortality and inequities without thinking about the trends that we're seeing in life expectancy in the US. And some of you may be more familiar with this, some of you may not, but we are actually seeing a decline in the average life expectancy within the US. And so in 2019, it was about 78.8. And then 2020, as the pandemic hit, it was about 77. And in 2021, it went down to 76.1. And so we are one of the few countries that is fully developed that did not rebound from the mortality rates that we saw with COVID. So many countries, the first year they saw a dip as well, but they were starting to kind of go back up, and we haven't really moved that far. In addition to that, we also have been seeing that the gender gap between women and men had been widening during this time as well. And so, it seems as though, and if you think about the statistics of COVID-19, men were more susceptible to die from COVID-19 than women. And one thing that's really startling is I was looking up just our research, trying to assess the relationship between looking at kind of where we rank compared to other parts of the world. And according to the UN Population Division, the US ranks number 47 globally on life expectancy levels. And there were some countries that were ahead of us that I was not expecting. And so those are things that, we have to kind of think about. It's easy for us to forget that, we live in a country with the best healthcare system, and we have access to like the best scientific strides, but then, most of the people who live in our country are not necessarily reaping all the benefits. And so kind of looking a little bit at this, it's not that, it's important to kind of look at these trends and also think about how this interacts with culture. And so across the board, when we're looking at life expectancy, it has declined across the board. But what we're seeing is that there are some populations that are struggling a lot more. And so just kind of looking at the Delta scores, which are basically the difference between 2019 to 2021, we are seeing that our American Indian population, they saw a stark decline of about 6.6 years, and the average expectancy for them in 2021 was 65.2, right? So that is something that, you know, we live in a country where some people are living, you know, have an average life expectancy of 83, and then another racial demographic that is struggling a lot more. And you also can kind of, and one thing that I think is also really important here too, is that when it comes to life expectancy, there are certain populations or certain racial groups that do better than white Caucasians that we generally don't necessarily always think about. So yes, Asians, but also Hispanics across the board and pre-COVID were more likely to live longer than Caucasians in the US, right? And then once COVID hit, because of the, you know, because of the fact they're usually the ones on the front line most of the time, and their jobs are the type that they can't always do from home, they were exposed more often, which is probably what caused much of the decline. But, you know, there are things that we have to kind of be thinking about in terms of those intersectionalities. One other thing that I always kind of am interested in looking at is, you know, how much do we spend on healthcare per capita? And, you know, compared to many other countries where people live much longer than us, we spend a lot more money on healthcare, right? And I'm going to kind of talk a little bit about why, and I'm going to kind of get into the disparities about, you know, where we're putting our money and why there may be some issues. And this also is related to much of the burnout we're seeing in nurses and doctors and pharmacists across the board, has a lot to do with the fact that we're not putting our resources in all those appropriate places to be able to manage the burnout. And so I always think it's important to kind of think about, you know, there are many other countries that are doing a lot better job, spending a lot less money, and people are living much longer. A few other things I want to just kind of quickly highlight is that when it comes to like the top 3 causes of death, across the board, it's usually either heart disease or cancer. And then once the pandemic did hit, we saw that there were some populations that struggled more, where that kind of came up as number 1. But we can't kind of ignore the fact that there's still a lot higher rates of people dying from heart disease and cancer. And there's been some research done looking at just mortality rates in cancer throughout the pandemic. And one of the problems has been that when the pandemic happened, many people were not able to see their doctors, or many people who had symptoms did not get tested till things got better, and it may have been too late when they were diagnosed. And so these are things that we have to kind of think about and look at. And there are some populations that in 2021, you know, COVID-19 was still that highest cause of mortality, right? And so these things are varying and changing. So now I'm going to talk a little bit about what some of these terms mean within the field of equity, and this can be related to, you know, social equity, or it could be related to health equity, and kind of talking about what are the major contributors to these factors, as well as what are the main contributors to health, right, and where we're putting those resources. And so the first thing I want to kind of quickly talk a little bit about is the distinction between health disparities and health inequities. And so a health disparity, all that is we're looking at different groups and seeing whether there are differences in their health status but the groups we put people into is kind of how we define it. So it could be race, it could be income, it could be education, it could be English language and literacy or disability, but that's really all they look at. With health inequities, what the focus is on is focusing not just on these differences, but focusing on how our socio-cultural status and how our societies is disadvantaging people from those groups, right? Where it's not that they were born with some genetics that may play a role, but more so, you know, someone's social identity or their status is kind of disadvantaging them. And these are generally circumstances or inequities that oftentimes may be unnecessary and avoidable if we just change our system, right? And so that's kind of the different ways of looking at it. And sometimes they're used interchangeably, but if we just focus on disparities and we're not thinking about how can we fix it? And oftentimes it's due to the lack of resources that are necessary to maintain health and well-being, right? So it's, you know, access, you know, living in an area where you can go outside and there's a park and your kids can play at, where you're not concerned about someone, you know, shooting your children, right? Having sidewalks on the street where kids can, you know, ride their bike in a safe manner, having neighbors that you can trust. And so a lot of this is kind of rooted in social justice. And when we talk about health inequities and health equity, one way I kind of think about it is the image that you see down there. So the image on the left is kind of like a health inequity where, you know, that little yellow child can't really talk or see the doctor, but when we try to make more equity, we're kind of giving them something to stand on. So now they're the same like playing field to be able to get access to that particular type of care that they need. And I really do like this quote that was created by that was said by Robert Wood Johnson. And it says, health equity means that everyone has a fair and just opportunity to be as healthy as possible. This requires removing obstacles to health, such as poverty, discrimination, and their consequences, including powerlessness and lack of access to good jobs with fair pay, quality education and housing, safe environments, and healthcare. And this is something that I really believe is powerful, not just thinking about poverty and discrimination, but really thinking about their consequences. I currently volunteer with refugees from Afghanistan, and I know of one or two who don't trust doctors and are so fearful of going to the hospital because the fact that no one was really able to translate to them what was going on with their bodies, and it made them so they didn't feel as though they can trust doctors, right? And so then they're less likely to go if they really need to get access, right? And so we have to be thinking about the trauma of the interactions that they have within those settings. And so one thing I want to just quickly highlight is that, you know, all of these things are interconnected and we can't ignore one versus the other. You know, oftentimes we like to do that, right? I teach stats. I'm a big data and stats nerd. And whenever people talk about it, stuff, like, we can't just do a t-test and look at these two different groups. We have to think about how these different things interact, or else we're going to lose a lot of things if we're not kind of looking at that. This is kind of where I think a lot of people are not necessarily fully aware of. And I think this kind of really gets at some of the reasons why we're seeing lower levels of life expectancy within the US is what research shows. And if you look at this table, the darker graph is the darker bar is the impact on health, and the yellow or the orange is how much the US is spending, right? And so what research has shown is that, you know, there are several known things that impact our health a lot more than other things. So for example, individual behaviors, right? People's diets, their physical activity, their sleep patterns, all, what they're consuming in the media, all of these things influence their behaviors, where they live, how they're reared, the people who, were parenting them, modeling these behaviors play a much larger role in long-term health than things such as just medical care, right? Which that's the first thing we think about, right? Other things that play a role is also, socioeconomic status, right? We kind of talked a little bit about that, looking at, education levels, but also social connectedness. We know that, individuals who live in communities that are more collectivistic, such as within, the Iranian American community or Iranian community in general, that does help to protect you against, health consequences. And also just cultures and traditions to play a huge role in influencing our health. And then after that is genetics. And I think this is an area where, the US in general is not spending enough money on, when 21% of the impact of our health is due to our genetics, but we only spend about 0.3% on doing research on genetics and biologics. That's a huge disservice, because that's a lot of individuals that may actually possibly have a healthier, longer life, or at least if it's not that long, they'll at least have lower levels of disability for the duration in which they are struggling with a lot of those things. And so you can see, there is stark disparities. And of course, as I mentioned, like environment, but, we're spending our money in areas that are more intervention based, where if someone is to the point where they really need those medications and they need these other factors, there's a level to how much a doctor can really do at that point, right? And, when we're spending all this money on something that's only 11%, when we can be investing it more in genetics and biologics, and even in individual behaviors and attitudes, higher quality preschools, parenting classes. In my institution, we have a janitor who she is pregnant, and I'm usually in my office till about 6, 7 when she comes in, and we'll talk. And sometimes I'll tell her things, and she, she doesn't even, and she's like, oh, really? I never realized, my 3-year-old is going to really internalize that, right? And she's like, I'm so grateful that you have this background, you can tell me this. And she always comes and leaves me notes if she has a question about something with her child, right? Or whether something is concerning her. And so I think, we need to do better in where we're investing our money. We're investing a lot more in, social circumstances and medical care, but not so much in biologics and individual behaviors, which, play a huge role in implications on people's overall health. And also environment. One thing I want to kind of highlight is that environment may actually play a larger role in the next 40 or 50 years due to all the things we're seeing with global warming and climate change. And we're seeing a lot more research looking at the implications of heat and humidity on health in general. And so that may shift over time, but at the current moment, these are kind of what the research is suggesting. So really, when we kind of look at this in general, we're going to talk a little bit about what social determinants of health actually means, but really only about 20% of the things that predict our health have to do with like quality healthcare and access to care. Majority of the rest is due to either our health behaviors, the environments that we live in, or our socioeconomic factors, right? So we need to be thinking about what are the ways or where are the places that we can put interventions into to help prevent people from dealing with healthcare consequences earlier than they should be. And I'm not sure how familiar any of you are with social determinants of health, but this is actually something that came out of the field of health psychology. And I did not have a huge background with this I never was really exposed to this during my PhD program, but as I had started to work within, my field and did my research, I started interacting with people who do a lot of this work, and it really resonated with a lot of the challenges I saw in, the communities that I was working with and doing research on. And what we know is that these social determinants of health predict about 80% of people's health and longevity. And majority of this, has to do with prevention in people's environments and their socioeconomic status, not only the healthcare access. And also healthcare literacy on top of that, right? You can have access, but if you're not literate and you're not able to understand those larger concepts, you're going to leave that hospital setting and not even know like what you're supposed to do with the medication they had given you. And so we know that education plays a huge role. Research shows that the higher level of education that you have, the longer you live, and the less amount of disability you're going to have as you get older. And a lot of this stems from the fact that you probably can do better research when it comes to questioning things with your doctors and, going and being more informed about what are the appropriate resources or sources you should be looking for when it comes to thinking about what you want to do moving forward with your health. Also, language and literacy levels, I think, play a huge role, especially when we're thinking about immigrants and refugees coming into the US. A lot of them come here not literate in English, and you will be surprised how many hospitals don't have any translatable button, so they can't even go to read anything on that website because there's nothing that you can press to translate. In fact, this semester, I had worked with a student of mine on a research project, and we weren't able to ideally do what we wanted to do because there was no way that we can do the pilot study in time. So we decided to just look at all the hospitals in the state of Connecticut, as well as like 3 or 4 other big refugee and immigrant hubs to see if they had any, like translation features. I think it was only about like 5% had, the rest didn't. And so then, nowadays with technology, that's the first place people kind of go. And if they can't even read what's on the website, how do they know, what they should be doing? Ironically, a lot of them actually had like information about language and translation on their website, like translation services, but it was all in English. And I'm like, the irony is people who are going to go look for that, they can't read what you're writing, so it doesn't even make sense why you're putting that in English. Other factors, of course, economic stability, right? So if you have economic stability, you're more likely to not be as stressed when it comes to, in everyday life, right? Not having the stressors of not knowing when your next paycheck is going to come, as well as having access to good, health insurance, right? And also having time. I think we forget the privilege of, having jobs that you can take a day off to go see your doctor, right? Some people don't have that luxury. They work 9 to 5, and if you take that whole day off, you can't go. And most doctors close at 5, right? And so oftentimes, like, we forget how privileged we are that we have jobs that kind of allow us to go see a doctor, and we probably still can get paid that day as long as we make up the work on another day, right? And so these are things that have like real consequences and that we just don't think about. And I kind of talked about food insecurity before. And then one other thing when it comes to just health and healthcare coverage is really kind of focusing also on access to primary care, doctors and specialists, and access to high quality primary care doctors and specialists. And it never hit me so hard about the value of this until I actually was teaching in the state of Georgia on the coast in Brunswick, right by St. Simon's Island. And it was astonishing to me how limited primary care and specialist care was there, where they would have you sign a contract if you saw a specialist that you wouldn't see any other specialists in that region because they didn't have enough specialists there, right? So people who live there could not go and get a second opinion, right? Unless they had a car and they can drive an hour to another region. And so, these are things that are important for us to kind of think about, is that, not just healthcare coverage, but is there access? And also linguistic and culturally competent services. And that doesn't mean just using the right language, but understanding where people are coming from, their cultures. If someone has to lose weight and they live in a particular culture, if you give them a sample diet menu that's very American and they come from an Indian culture, they're gonna be like, I don't know what this means to me. I don't have white bread that tastes like cardboard. I make rice, or I bake my own bread. And so they're not going to receive it if it doesn't really align with what they eat normally. And so helping people to, being more in tune with that. And then other things are neighborhood and, environment. So not just thinking about not just safety, but also environmental conditions. So is there radon in the homes, the water quality, walkability? Are there safe sidewalks or bike paths? Are there safe parks or playgrounds? Is there access to transportation, and also access to quality foods? Oftentimes, many individuals that live in lower income regions, there are a lot of food deserts where, if you live there and you don't have a car, there's nothing in walking distance, where there's no place you can go to go get an apple or a banana. Usually it's like a 7-Eleven where it's mostly junk that's there, and it's hard for people to get access. And even when they do, oftentimes there's been economic research done that shows that people who live in lower income areas, the prices of food are higher than people who live in higher income areas, because they know that many of these people who are lower income can't afford to get to drive somewhere. So they'll just get whatever is there, right? So there's a lot of disparities in that as well. Meanwhile, people with higher incomes, they know that they can drive and kind of see where they can buy the cheapest things. And then, of course, this typical social and community contacts, civic engagement, discrimination, social integration, all of these factors that play a role in how people perceive the healthcare system and how likely they are to kind of trust the healthcare system. And as I kind of mentioned before, place matters. So if you look here, this is kind of a graph of life expectancy, and the red is very low. The purple is very high, and then at blue is a little bit higher, and then the green and yellow is somewhere in the middle. And you definitely see there are these trends. There are these pockets of areas where it's people are living much young, people are dying at much younger ages, and then there are areas where people are living much longer. And I guarantee you, if you put socioeconomic status on top of this, it probably is going to overlap quite a bit. And I'm going to skip that slide due to time. And how much time? I just want to make sure I don't go over as well.
Maybe 10 more minutes.
Okay. And so one other thing I wanted to kind of quickly talk about when it comes to social determinants of health, oftentimes we kind of consider these factors almost like preventative components, right? And the field of medicine is more intervention based. Once people are sick, we treat. And there's been a shift even in the American Medical Association, where they're starting to realize that, okay, it's great that we're doing all this prevention. I mean, we're doing all this intervention, but people are coming in with issues that could have been prevented if only these other factors were addressed early on. And so there's been a big shift to kind of focus more so on these social determinants of health. If we can change some of these systems, then we're less likely to have to invest so much resources in interventions. And so one great quote is, there comes a point where we need to stop just pulling people out of the river. We need to go upstream and find out why they're falling in. And this is something that has led to the American Medical Association's equity mission and strategic plan that was developed in 2021, where they actually develop these goals and priorities where they believe that we need to focus more in the upstream instead of that downstream, right? What are the things that we should put more effort into, community education, right? Health literacy, educating teachers and doctors, trying to improve living conditions in various regions. So this way we're not as overburdened where, like we are today with our healthcare system. And so they developed a whole equity plan that kind of looks at various different, components in that. So, and some of it is kind of ensuring that they're using innovation when it comes to working with marginalized and minoritized people and communities. I personally don't think we do a great job with that. And from my experience working with a lot of refugees that I have, I mean, the trauma, even for me, when they would come to me asking me questions about things because they went to the doctor, they didn't understand what they were saying about their grandmother. And then they give it to me and I'm like, oh, like, I don't feel as though I should be the one telling them that your grandmother has cancer. And how do I explain that to a 13-year-old who's still learning English, but knows more English than, her grandmother that's 75. And to think that they had gone to a doctor that somehow cannot communicate that and gave them this little paper and wanted someone else to, like, made me kind of question that. And then I thought things were getting better. And then about 6 months ago, one Afghan refugee that I work with, a woman, I do tutoring with her. She had kind of told me about her experience here and how she doesn't like the hospitals. And she had mentioned to me that she was hospitalized for a month and a half at the Yale Hospital, mind you. And we have, I had all these ideas about how fantastic it is. And she ended up going in for a headache. And she told me, she's like, yeah, I understood. Finally, I figured out they were mentioning to me about my thyroid. So they took it out. About 3 months later, she comes to me and was asking me questions about medications that they gave her. And, about this, it was vitamin D supplements. And then I was like, oh, like, if you have any other questions about your other medications, let me know. And she's like, I'm not on any other medication. And I'm sitting there thinking, they've removed your thyroid. Like, so of course, at that point, I was trying to maintain my composure. And I was able to kind of quickly call a friend, and they're like, well, did they remove her whole thyroid or partial? And when I asked her, she was like, oh, well, they didn't communicate it very well. They had someone like you who is Iranian. Farsi is kind of like their second language in essence. And she didn't really know, like, medical terminology in Farsi. So I didn't get it fully. And I'm sitting there thinking, like, this person had a surgery and doesn't even fully know whether they took out, her whole thyroid or partial of her thyroid. So, these are things that, we don't necessarily think about, but they have long lasting implications. And so making sure that, we are embedding innovations like such as something as simple as a translator on a phone that can quickly, translate and make sure she understands it. But there are definitely things that we need to be focusing on. And of course, that idea of pushing upstream. And then the last couple of things that I want to kind of talk a little bit about is, like, just how a lot of these historical issues have led to, like, layers of distrust in a lot of marginalized populations. And if we don't start talking about that and addressing that, they're never going to start trusting. And it's something that is usually very challenging to do, but it's really important for us to kind of be thinking about. And so the one area, for example, is just how we like dehumanize different marginalized groups within the US. And we see that with a lot of Iranian Americans as well, where it's like if you look at many of the news images, they don't always show the faces, they just show the body, and they don't make them seem as though they're human, right? And after a while, that does impact many of these people that have lived experiences with that. And, oftentimes there's a term known as intergenerational trauma, where, if your ancestors had experienced trauma, that shifts their genetics and DNA. And for a few generations, people who may have not been alive during that trauma, their genes are still altered a little bit. And so for many of these individuals, it really kind of is in their bones when they're living in, long-term community, generations of just trauma that is happening. And we're seeing this a lot, with a lot of the national debates within the US. One that has been really challenging for me is the whole Israel and Palestine thing, because I think both sides, whenever I hear conversations, I'm like, they're all just humans. Like, let's just put it down there. All the civilians on both sides are humans, and let's first put that there before we have these other discussions. But we're seeing it across the board with different demographics. And oftentimes many of these people feel as though they're just expendable, like this idea that, we can just get somebody else if they, and for many immigrants and migrants, they really do feel as though they're expandable. I mean, there's not much, someone else can just take up their job and that's it. So in terms of some of the things that we can do, first and foremost, regardless of your discipline, like just provide educational and training materials with credible sources in an accessible manner. And so I have colleagues of mine who are like, well, I teach like mathematics. I'm like, well, you can teach them about math literacy so they can learn what these percentages mean or where the data comes from, right? There's so many different skills that can be translatable. Also just collaborating across sectors, right? So it's not just, it's not just the field of medicine, it's not just MDs and doctors, but even working with churches and schools and community centers and psychologists and public health. And, even nowadays, geophysics with climate change and the implications we're seeing on health, like trying to figure out what are the ways that we can slow that down. Try to reduce cultural barriers to care. So something as simple as having a translate button on a website, which you can get through Google, can make it much easier for people to get access to. And also just normalizing conversations about like racism and other forms of oppression, which I think we tend to just not like to talk about. And I mean, I see it in academia all the time with even faculty that don't want to open up about it. And I'm like, if we don't have these conversations, then nothing is ever going to change. It's okay to bring this stuff up. But oftentimes, people are just so fearful of losing their jobs that they don't say anything. And I always tell individuals that have like security behind them, like come from privileged backgrounds, to say something. Because if we don't, no one will. Some other things is just trying to build an internal culture that values spaces for like psychological safety and trust telling. That can take a really long time with marginalized populations or people who've experienced trauma. The refugee I started working with about a year and a half ago, there was some trauma she had experienced, and it took about, I would say, a year before she finally, one time I went to work with her and I couldn't tell whether she had a learning disability or whether there was trauma going on, because she just was not retaining things and all over the place. And she finally at that session was asking me a lot of like questions related to my upbringing and my culture and expectations of women and men in the US. And then all of a sudden, things came out where I've been working with her for years, seeing her every single week and speak, we were able to communicate, but yet it took her that long to feel comfortable enough to tell me, because she's fearful that what if I tell someone else and somehow she'll get kicked out of the country or something, right? These are things, and it was illogical, but she, when you came from Afghanistan, you don't know what may happen, she's used to that. And so realizing that this stuff takes time, integrate trauma-informed practices and lenses within all disciplines. And just because someone's an MD, just because someone's a faculty member, just because someone's the president of the US doesn't mean that they haven't experienced trauma. And that trauma can impact the decisions that they make, right? And so ensuring that we're being conscientious of that as well. Building alliances and sharing power with historically marginalized individuals, and just getting to know people from different backgrounds, I think is really important. And then, of course, trying to push upstream to address all the determinants of health. So I think I'm going to kind of stop here for now. I had a few other things, but I don't think they were as important. I do want to give an opportunity for questions. I know some people already have their hands raised and